Vishal, thanks for your kind introduction. I'm delighted that I could actually make it cross town. It only took 2 hours today. So I have been tasked in the next 10 minutes to tell you all that there is to know about data for Fempop disease. And so I know, Prakash, you've started to cut our slides off, so I'll go really fast. I have numerous disclosures that are germane to this, but I'll try to stick to the evidence. Normally, when I talk about SFA disease, we go through everything that you've already heard. We're really just going to talk about the anatomic and clinical tools for revascularization. I would highlight for those of you that are cardiovascular medicine specialists that these are the guidelines currently for SFA disease. In about a month, there will be new guidelines that will be issued, but I don't know that there'll be much in the way of new information that'll be covered. For our surgeons in the room, obviously you're well aware of the SVS guidelines, which I think are similar in many respects. And I do recommend that you use this document for definitions that I might include. You've already learned about all the medical guidelines for the management of these patients. There will be some new guidelines with respect to anticoagulation that I anticipate will be in the new guidelines next month. But as we've talked about repeatedly, the management of PAD really is dependent upon the clinical status. Patients who have stable disease, patency is the #1 outcome measure. And for the SFA, that's really the outcome measure that we really are looking at when we're comparing evidence between technologies. The reason we treat inflow before we treat outflow is largely dictated by this fact. Patency rates of our big vessels are much better than those of the Fempop segment. And the reason that people were so reluctant to treat the SFA with endovascular techniques is because of this wide variability in patency. And consequently, we have relatively muted guidelines for whether we should treat the SFA because it's something that's complicated by restenosis. So whether it's the appropriate use criteria that we'll talk about or other criteria, the fundamental complication is that the SFA is a difficult vessel to treat because of all the stress and strain forces that are applied. And if you take a bent knee lateral of, for example, a stent, this is a standard nitinol stent in the Hunter's Canal territory, you can see that the stent is essentially crushed by the natural forces. So the SFA is a bad place to treat. We don't really use this task guideline, but we do need to bear in mind that if patency is the metric by which we're judged, Fempop vein bypass is still probably about as good as anything else that we've developed because it has a patency of approximately 75% at 5 years. Once you don't have venous conduit, the patency rate falls off dramatically, and we clearly have equipoise with PTFE for the Fempop segment. Stents were shown initially, now over 15 years ago, to have superior patency to plain old balloon angioplasty. So anybody that's just doing POBA for the SFA is essentially dooming the patient to a 50% restenosis rate at 1 year. So if you're treating a claudicant with plain old balloon angioplasty, you're basically performing a coin flip type of procedure in that the patient will likely have restenosis of 50% at 1 year. Stents, on the other hand, aren't really any better. There's maybe a 60% chance that they'll be open at 1 year. And every vendor has a slide like this, that their freedom from TLR is about 75% at 3 years' time. The way I look at it is that there's a restenosis to length relationship that's linear. And I use this paradigm because I think it's helpful. If you have a longer lesion, there's a slope that's linear for balloon angioplasty and a slope that's somewhat flatter if you use a nitinol stent. So how do we flatten that slope further? Well, we develop better technology. The Supera stent has now been in clinical practice for over 15 years and has been approved for at least 8-9 years. Interwoven nitinol clearly has freedom from clinically driven TLR and primary patency when deployed nominally that's superior to standard nitinol stents. And the important thing to realize here is that once the stent is deployed, after the first year, there's very little drop-off in primary patency. So if you can get through the first year, you'll have a very good long-term result. Here's an example of a bent knee lateral with a Supera stent. In addition, drug elution really has revolutionized the field. I'm not going to perseverate on it, but suffice it to say, in other vascular territories, drug-eluting stents are the de facto standard of care, and there's no reason really that shouldn't be the case for the Fempop segment. The way the drug works is it gets through the artery from the luminal interface it diffuses across the wall of the vessel, and then its effect is really proportionate to how long it's in the artery at a therapeutic concentration. There's a number of different ways of getting drug into the artery. The drug-coated stent like Zilver, the drug-eluting stent like Eluvia, a drug-eluting balloon that will soon be available for research trials from Caliber Therapeutics or Orchestra Biomedical, and then the standard drug-coated balloon, which is basically every other drug-eluting device that we have in clinical practice. The way DCBs work is they drop a huge payload of drug on the artery wall, and as much of it as possible will bind to the vessel, and then this will be cleared gradually. The effectiveness is proportionate to the area under the curve. Drug-eluting stents, on the other hand, work by giving a slow, steady dose of drug over time. And again, you can make the area under this curve bigger because you have the ability to control the release of the drug. Zilver was the first to demonstrate the value of this compared to primary balloon angioplasty and stenting. These data are now over 10 years old. But we learned that certain first principles apply. If you have long lesions, small vessels, you have higher restenosis rates. And you also need to keep the patients on antiplatelet therapy. So the next generation drug-eluting stent, the Eluvia, when compared head-to-head, was superior in terms of primary patency, and this was carried out over 2 years, and also in patients with diabetes, with chronic total occlusions, with calcified lesions, and even in long lesions. When compared head-to-head with other nitinol stents, not surprisingly, Eluvia has shown to have superior primary patency. And so, really speaking, there's no reason, in my opinion, that you would use a standard nitinol stent if you're not using adjunctive drug therapy. And so this is the 2-year data for Eluvia. What about drug-coated balloons? Let me go back. Each of the drug-coated balloons works a little bit differently. You can't consider them a class effect. Here's a work from our lab at CRF from Juan Granada that if you take 3 different drug-coated balloons, in this case Lutonix, Impact, Admiral, and Ranger, they all deliver a lot of drug, but some of the balloons are able to have the drug retained in the artery for longer. So take, for example, Ranger and Impact have more area under the curve than Lutonix, which exactly predicts their clinical performance. It's not surprising that the Impact has excellent long-term primary patency. The same is true when you compare a balloon like Ranger to Impact. They have similar pharmacokinetic profiles, even though the amount of drug on the Ranger is roughly half that of the Impact. So as long as there's enough drug in the artery for long enough, you get a sufficient result. Doesn't matter how much drug is on the balloon. So all this marketing about low or high dose drug-coated balloons is not really relevant. Again, and this is just comparing Ranger to Impact. This was done in Germany, 12 months, randomized in short lesions with and without bailout stenting, and all kinds of lesion lengths out to 30 centimeters. Really no difference between the two devices in terms of patency, which is the outcome measure we care about. So the other thing to remember is that most drug-coated balloon trials, especially once we go into the real world, the longer the lesions get, the higher the percentage of bailout stenting. So in the real world, drug-coated balloon angioplasty really is a complement of drug-coated balloon with standard nitinol stent bailout stenting in roughly 40 to 50% of the cases. So if you're comparing data apples to apples, that's really what it boils down to. So now we have this Chinese food menu of options for treatment of the SFA. Many of us societies have put together appropriate use criteria, but in my opinion, you have to ask yourself, why wouldn't you use a drug-eluting technology if primary patency is the goal of your intervention? So particularly for the claudicant, I think a drug-eluting technology, whether it's a balloon or stent, is highly relevant. And that's really how you flatten this curve to get us equipoised with surgical revascularization for the FemPop. This is my personal algorithm. It's just born out of my own experience, but really for long segment disease, I use lots of drug-eluting technologies, DCBs primarily, occasionally primary drug-eluting stenting, but it's usually DCBs supplemented by spot stenting. We use adjunctive therapies relatively frequently, but they are only adjunctive. They're never really designed to be primary definitive therapy. So again, to a hammer, the world looks like the nail. Most of SFA disease can be probably handled exceptionally well with endovascular techniques. I will, in the last 10 seconds, just close by saying that this conversation about paclitaxel being a lethal compound in human SFA intervention has largely been debunked. The data from the Voyager PID study shows no mortality hazard. Similarly, from Sweden, in a randomized fashion, no mortality hazard. And so I think that story has been put to bed. So I think, Prakash, in 10 minutes, I was able to sort of cover the landscape of data for the SFA. There's lots of data, more data perhaps here than in any other space. But certainly, if you're not using drug-eluting technologies, I think you have to ask yourself why. Thank you.